Welcome back, everyone, to Clinicians Brief the podcast, where we get to explore the conversations behind the content. I'm your host, Dr. Alyssa Watson, and I have a very special guest today, Dr. Elizabeth Drake. Dr. Drake is an associate professor of small animal dermatology at the University of Tennessee. Our conversation today was inspired by her recent Clinicians Brief article, Skin Biopsy for Diffuse Dermatologic Disease in Cats and Dogs. Today, we're going to talk about how to correctly describe some dermatologic lesions, as well as discuss which diseases are best identified through skin biopsy. Dr. Drake is also going to walk us through the procedure and provide some practical tips. So if you're looking for ways to improve your chances of getting accurate skin biopsy results, you're in the right place today. Thank you so much for joining us, Dr. Drake. How are you doing?
Thank you. I'm wonderful. Thank you very much. Appreciate it.
Before we get into our conversation, and I have lots and lots of questions about skin biopsies for you, I would love it if you could just introduce yourself quickly to our audience, give us a little background. I know you spent a little time at Iowa State University, which is my alma mater, so I'm sure our audience would love to hear about that.
Sure. I'm a Texas A&M graduate, 1997, just a few years ago now, and I was in general practice, small animal practice for 4 years in Houston. Really busy practice. In fact, my former boss just announced her formal retirement yesterday. I happened to see it on Facebook and thanked her profusely for my experience with her. I did a residency soon after that here at the University of Tennessee. Left for about 10 years, was at Iowa State for about 10 years with Dr. Noxon, we all know him well. And then I was lured back to Tennessee in 2013. I've been back here since and love my place. This is my home, although I miss Iowa all the time and have the Cyclones on my sports calendar, follow football and basketball.
Absolutely. And at the time of recording, we're coming up this weekend is the Iowa State Iowa game. So that's where we will be on Saturday.
Oh, good. That's so fun. My house was right by the stadium, and I really miss it this time of year.
Yep, absolutely. So I graduated shortly before you came to Iowa State. So unfortunately, I didn't get to have you as one of my professors. But back then, I was taught that the standard kind of minimum database for skin disease included a fungal culture, deep and superficial skin scrapes, and then cytology of the skin. And that was kind of drilled into us. I'm probably dating myself. This was before we had fantastic things like all the Lanners and PCR testing for ringworm and things like that. But is that really still, kind of the baseline recommendation? What are the recommendations these days?
The modifications of that. It really depends on the skin lesions that are present. And so for dogs, most of the time, almost every dog we see has some kind of superficial skin infection or an otitis. And so if it's indicated, then superficial skin scrapings, deep skin scrapings, especially the first visit. I rarely fungal culture dogs anymore because the carry-on is the typical presentation. And these are usually superficial crusting, alopecia, kind of itchy things. And so fungal cultures for cats, absolutely in the beginning, but for dogs, it's mostly getting really comfortable with ruling out demodicosis. And to be honest, we've seen some referral Demodex cases lately, and I thought we would be done with that after all of the different, as you mentioned, the Lanners that are available. And I was kind of afraid the students would never see the disease. But we've seen a few cases. So yes, superficial skin scrapings at the beginning. Not forgetting the deep skin scrapings when you have a really, really itchy dog and you suspect scabies, for example. And then I think where we really lack communication skills and just good instruction is how to get a good superficial pustular crusting cytology. We use tape a lot for certain locations, but I think we miss out on, I'm not able to communicate clearly sometimes how to get a really good juicy cytology sample with a glass slide from under a crust. Explaining that can be challenging. I ask the students all the time, do you remember the exercise when you did gave instructions how to make a peanut butter and jelly sandwich? And they kind of look at me quizzically, but it's kind of the same exercise. How do you explain that quickly? And I'd sort of love to do step-by-step picture video or, document or something. It's not hard, but when you try to explain it, it doesn't seem very logical.
That's one of the nice things, I think, for our audience, after they've listened, go check out this article on the Clinician's Brief website, because there's fantastic photos that go along with it. And that can really help, I find, to dig deeper and get some insight on how to perform a lot of these procedures. So we are talking about skin biopsy today.
Mm-hmm.
And so what types of conditions are skin biopsies really kind of essential in order to diagnose? I always think of immune mediated disease, but are there
Mm-hmm.
others?
Certainly, anything that's deep and draining or nodular is going to be good. So anything that might be a neoplasm or a mass of some sort, or just a deep draining infectious or sterile condition, autoimmune especially. Anything that's ulcerated or crusted, deeply crusted, where the skin is completely eroded or ulcerated is important. So drug eruptions, deep draining things, masses, those are the kind of things we want to biopsy. Some of the hair loss conditions. But for the vast majority of our workup, skin biopsy is not an everyday tool that we would use.
And then there are a few really common disorders that skin biopsies really aren't helpful for, right? So why are
Mhm.
skin biopsies less reliable when we're looking at diagnosing things like allergic skin disease or skin disease that's secondary to endocrinopathies?
Mhm. Sure. I mean, those diseases are more based on ruling out other conditions, and clinical signs are really, really important when you're differentiating those conditions. And some of the biopsies, for example, if you're looking at an alopecic disorder like the Pomeranians with alopecia X, their biopsy is basically the same as any of the endocrinopathies. They have similar features, and so you wouldn't be able to tell that dog based on biopsy from a hypothyroid dog or sometimes a dog with even Cushing's disease. And so there's just a lot of overlap. And so clinical signs are really, really important, and biopsy is only a part of the puzzle or part of the workup in those cases.
I've found that there are, especially, the main commercial labs that we use, that I use in clinical practice, that they actually have a separate test code for dermatohistopathology versus kind of
Mm-hmm.
the standard histopath that I'm using if I, excise a dermal mass or something like that, or take a liver
Mm-hmm.
biopsy.
Sure.
And so other than, is it really important to select this service? Number one, like, how important is it to say we really want a dermatohistopathologist? And how can we make sure that pathologist reading the samples is really well versed in skin lesions?
That's an excellent question, and I feel like it's very, very important to understand what the service actually is offering. I have some colleagues and friends that have worked for the various laboratories in the past, and that may not include the dermatologist. Sometimes it's the dermatologist reviewing the report and then interpreting what the pathologist has written, and they may not see the slides at all. And the definition of a dermatohistopathologist is a little bit fuzzy in our practice. We have a lot of pathologists that are interested in dermatologic diseases, but there are very few people that just do veterinary dermatology pathology. And so with the commercial labs, I would just double check and make sure you know what you're ordering, because sometimes it is just an interpretation of the report, and that's not a bad thing. It's just that it may be misunderstood what the expectation is.
Yeah. So just like everything else, really open lines of communication, pick up the
Hmm.
phone, call the lab, things like
Hmm.
that.
Hmm. Yeah.
Are there some other ways that we can, help the pathologist out on our end? Could you give some examples of what kind of clinical history do we need to be including? Obviously where the lesion is, what it looked like, but how detailed do you get? How much information do you give the pathologist about things like response to previous treatment or diet history? And are those things really helpful?
Another excellent question. History is essential when you're ordering these tests, and the reading these slides blind without any pictures or information is extremely difficult. Actually, that's part of our board's training preparation for our residents, and it's hard. We have the advantage of the pictures of seeing the dog and examining the dog, so any kind of distribution is really helpful. Is it symmetrical, asymmetrical, acute onset, chronic onset? Is it only the white hair that's affected, or the white-haired areas, or is it only the dark-haired areas, or is it just on the feet, or just on the one foot, or versus both front feet? Or the distribution and symmetry are really, really helpful. And then describing the lesions is make it as simple as possible. If it's draining or nodular or ulcerated, that's really, really important as well. And if there's an opportunity to select some clinical photos, I think that's really helpful for the pathologist. As far as treatment failures or successes, I think grouping the treatments together is sufficient. So non-responsive to multiple courses of oral antibiotics and steroids or something like that, diet trial isn't really going to be helpful. And if there's any previous biopsies, especially from another service or another clinician, potentially including that information would be really helpful for the pathologist.
Absolutely. I think having the availability of smartphones and recording devices, with us all the time has really changed the way that I've practiced. I know I can get a lot better photographs. Oftentimes, if I'll put my phone on video, and take a short video and move, open, spread the toes to look at lesions between, things like that, and then you can take a screen grab of those types of things. And I know for me that's really been helpful as a way to communicate to other clinicians, what I'm seeing. So it's just something that I've found helpful.
Yeah, it's trying to interpret dermatitis or skin disease is really challenging, and I really give them a lot of credit for what they're able to do.
So let's talk a little bit about preparing the patient. Okay, so I want to talk about like the actual patient. We're going to talk about how to prepare the skin, how to prepare the lesions, but oftentimes we need to change or discontinue medications that these patients have been on before we do skin biopsies. So what, like, different immunosuppressive agents, how can those influence our skin biopsy results?
Another excellent question. I just had this conversation with a veterinarian a few days ago. Really, the only medication that's going to interfere with interpretation is corticosteroids. And that includes topical steroids or systemic. And that for systemic, I mean, even eye drops, ear drops, some of the really potent ophthalmologic medications can affect the skin lesions. But back to the cytology I mentioned earlier, what I tell people is if there's active disease and you can take a cytology sample and see something that would be consistent with what you suspect, then biopsy is by all means indicated. And that's the hard part, is knowing if the cytology sample is useful and knowing what you're looking for with a differential diagnosis list. So it's a hard question to answer. How long to discontinue the medications is really dependent on how active the disease is. Some of these dogs are ill and have fevers and different clinical signs, and so making them suffer for weeks on end before biopsying seems a little nonsensical, but we also want to get an answer. So back to that cytology, which is really useful. If you see lots of inflammatory cells and things you're looking for, then probably a good chance you'll get an answer.
Definitely, I have heard of cases and had cases of my own where infection has really complicated the results that we get from biopsy. So what are some clinical clues that we really need to address infection before we proceed with skin biopsy?
Yes, that's a complicating factor, especially if we're looking for very small changes in the epidermis, for example, some of the crusting diseases. And so if there's any bacteria, looking at a cytology sample underneath the crust or something is useful. If there's no bacteria, then probably plow ahead. It never hurts to do a short course of topical antimicrobial therapy like chlorhexidine. We use a lot of topical therapy, and that doesn't mean necessarily a wipe or anything, but a spray or something like that could be very useful. We actually use a lot of 2% chlorhexidine solution, the blue stuff in the jug that's really available pretty much everywhere, and have people use cotton balls or something to dab it on there. You're trying not to disturb the architecture, but you also don't want a whole lot of infection, because you're right, exactly. You'll get reports back that are very murky sometimes.
Are there times, you said you really rely quite a bit on topicals there? Are there times where you're moving to systemic antibiotics? And if you do, what is the first line choice of antibiotics you're using there?
With widespread disease where it's really impossible to treat every lesion topically, then systemic medications, of course, are definitely important. And the cephalosporins are still really good choices. We're just seeing a lot of resistance, at least in our area. And so unfortunately, it's getting less and less easy to predict the susceptibility pattern. It's gotten even more restrictive than it was even a few years ago, even maybe last year. So I'm not sure what's happening, but if cephalosporins are not improving the condition, then you may have a resistant infection, or you may have a truly non-infectious condition to deal with.
So you mentioned that really corticosteroids are the only thing that's going to affect your biopsy results. Does that mean we don't need to have a washout period with other medications like antihistamines or oclacitinib?
Correct. Very few medications do what steroids do, which is why they're so well loved and well used. And for most conditions, the other medications, as you mentioned, cyclosporin, oclacitinib, lokivetmab, all of those are probably rarely going to be problematic. There are very rare exceptions where Apoquel might affect a diagnosis with something like a vascular inflammation, but very rare. And so I would really just focus on the steroid drugs.
Okay. And then when you are doing these skin biopsies, do you find that sedation is absolutely necessary? Do you use general anesthesia if your patient is very painful? Could you just kind of walk us through a typical sedation protocol for a dog or a cat?
Certainly. I'm an optimist, and I have tried many times to bypass sedation, and I've regretted it pretty much every single time. And so even just a little bit of butorphanol or whatever you use for sedation / pain control can be very useful, just relaxing some of these older patients. So pretty much most of dexmedetomidine and torbuterol or butorphanol is what we use for a pretty standard protocol for biopsies. A little aside, when I was in general practice, before I did my residency, no one told me these things. And I didn't know that lidocaine burned because it's so acidic. And I would anesthetize my patients to put the lidocaine in, which is completely illogical and makes no sense. But I tell the students these stories all the time so they don't feel so silly. Because you look back and like, wow, that was really unnecessary, but no one told me these things. And so basically a little relaxation for a little chemical restraint just to relax the patient. And then a local block is pretty standard. My own dermatologist uses the same mixture that we do. And I dilute my lidocaine, the standard lidocaine formulation with 50% sterile water and just sometimes a little touch of sodium bicarbonate to balance the pH so it doesn't sting nearly as much. And from personal experience, I can say you don't feel a thing, although our patients seem quite dramatic. So I'm not sure I can equilibrate. That's not a good word. I'm not sure I can correlate my experience with theirs, but yes, sedation, I regret it every single time I haven't done it. And then the kitty cats, we just sedated a kitty cat last week for a procedure, and for the cats, the same kind of protocol works quite well, and we're very familiar with it. There's always an exception where you have a dog with a heart murmur or something that precludes that protocol, but for the most part, just a little light sedation is very helpful, and then some good local block.
Good local block. And we'll talk a little bit after the break too about, where we're putting the local block and how to avoid any complications with that. So
sure. I think you asked me about general anesthesia. I didn't mention that. The only conditions I really, really like to use general anesthesia for is biopsying things on the face, especially the nasal planum, and then the paw pads, where it's just so sensitive and really important to get good samples and be able to control the hemorrhage.
Yeah, that makes total sense. And I always want general anesthesia for anything around the eyes too. I'm always so paranoid. Yeah. I don't even like to scrape around the eyes. So
yeah, we don't either. And we have these little dental spatulas that are fantastic that we use around the eye, or the tape, but that's another topic. But yes, I know the eyeballs are not my favorite location either.
Looking for that special clinician or veterinary nurse to fill your job opening? Job seekers from all areas of veterinary medicine can meet their ideal match on the Clinician's Brief Career Center. It's the best place to post your unique job opening and know it will be seen by that special someone. Get started at cliniciansbrief.com/career-center. So let's dive a little deeper into the procedure itself. Let's start with talking about punch biopsies. Those are the ones I use most commonly. So when you're using a punch biopsy, is there a particular size that you prefer, or does it depend on the lesion that you're sampling?
I use a 6 millimeter punch biopsy for the most part. 4 millimeter punches for anything that would be potentially disfiguring to the patient, such as the nasal planum. You can get quite a few samples from even a small dog nose if you have a 4 millimeter punch. I rarely biopsy the pinna, but if I'm going to, a 4 millimeter punch is the way to go. And if you have a large dog, like a Great Dane or something, or a large lesion, an 8 millimeter punch can be utilized. Usually we reserve that for our large animal patients, but occasionally I'm removing something benign that I know is a sebaceous hyperplastic lesion or something, and it might fit inside an 8 millimeter punch, and that's handy.
And then what type of lesions do you think a punch is not appropriate for, that we really should be using an incisional or that wedge biopsy technique?
We just had this experience last week again. Anything that we can remove in entirety easily is, I think, a good sample for an incisional or excisional biopsy. Wedge biopsies, sometimes on the digits, if we're doing a biopsy on the claw fold or near that area, sometimes an excisional biopsy is useful. But I'm pretty much a punch biopsy kind of person most of the time. I can't remember the last time I did a wedge biopsy, but that doesn't mean it's not indicated. I just don't tend to do them.
And then is there utility to, I've heard differing opinions on whether or not you want to get your sample like at the margins of your lesion. You want to
Mm-hmm.
include normal looking skin. I've heard other people say, no, that's really not necessary. You want to go at the center of your lesion. So what are your opinions on that?
This is a very difficult topic to find anywhere where it's fleshed out really nicely. But one of the recommended reading recommendations on the feature, Anne Hargis and Sonia Bettany are the authors. It's a wonderful little tiny spiral notebook or spiral textbook, and it explains all of this. And it's the only source that I've really found that I found that it was clear, and it was actually very, very, very well done. And this is sometimes challenging, and what you really want to do is you really want lesional skin, and that's sort of near the edge. But one of an example recently was a veterinarian called me and asked me for asked some questions about the biopsy report, and it was a very well reputable laboratory and a pathologist that I know, and the veterinarian had biopsied the nasal planum, but the section she was questioning me or asking me about was talking about haired skin. And that's not what we were talking about. And so it's not something I would have caught as a practitioner. I just, because you're reading the bottom, you're not reading all the words that say all these big things. You're looking for what the interpretation is. And so when I asked her, I said, "Did you biopsy haired skin?" And she said, "Well, I didn't intend to." And so that's what happens when it's half normal and half abnormal, is the haired skin, or what's normal, might be what is processed. The whole biopsy is in the paraffin block, but they may not be slicing that section. And so that's why lesional skin is so important, to give them as much as possible. And then if you have a section where, for example, a condition where the skin, you want to send some normal skin. For example, some of the alopecia disorders, what looks normal might not actually be normal. So I'll send another piece of normal looking skin and label it separately in a separate container as clinically normal or visually normal, grossly normal skin. And that way they have an opportunity to look at all of that. Otherwise, some of these little things just get by when you're busy. General practice is a hard job and there's a lot going on. And so really getting your lesion in the middle is important, and then not discarding any of the material that's attached to the section. So if you're biopsying an ulcer and you just give them an ulcer, then we know it's an ulcer. Like that's not usually going to be very helpful. You want some diseased skin adjacent to the ulcer. And then also the other thing that's tempting is to throw away the scab or the crust that's on top of that. And that's where the information is. So we don't want to do that. That's the most important part, sometimes gets discarded. And so if anything falls off of your skin while you're taking it, get it in the jar with the rest of it and give it all to them.
And I know that sometimes you can inadvertently, just in your tissue handling, inadvertently cause some artifacts if you crush your tissue too much with your forceps, or even when with your punch biopsy blade if it starts to become dull, things like that. So how many samples are you generally taking, and how many times are you taking a sample before you discard, your average punch biopsy?
Usually we can get about 3 samples out of one instrument. If the skin has got quite a dense hair coat remaining, we may trim the hair. We're not going to clip it, but we might trim it to make it shorter. But that's going to dull the blade really quickly because it's like sandpaper essentially, and so very abrasive. And so you might just get 1 or 2 out of a sample like that. But when there's a lot of hair that's present, just be prepared to have to change it more quickly.
And then in your article, you actually suggest marking the lesions that you intend to biopsy. So how do you do that, and why do you find that that's a really important step?
I actually just use 4 dots. So I make a kind of at the corner, each corner. And to be honest, part of it so I know what I selected, so I don't forget when I come back around and I'm like, oh, what did I pick here? I'm looking for a variety of lesions. And so one of the things that is always in my head when I'm picking lesions is I want something that looks different. So whatever looks different is what I want to sample. If there's a crust, a papule or a pustule, I want that. If it's an alopecia erythematous area, I want that. So I'm dotting so I can remind myself, A, what I chose. Also, I'm going to describe the lesion. If it's a crust, I'm going to put, section 1 is crust. I'm going to put that in jar number 1. So I can correlate my clinical lesion with the piece of tissue I put in the jar. So it's a lot of it's for me for organizational, reasons. And also, whoever's suturing knows where I was taking my samples, and so we're kind of following behind each other. But that's most of the reason I'm looking at assessing what I've chosen to see if I still agree with what I chose, and then going from there. So it's useful, and also if I have students with me, they can see what we're doing as well.
And then this is the time we probably want to talk a little bit about local blocks, because I said we would. So are there, what kind of complications can we cause artifacts giving our local block? What are we trying to avoid there? And how can we maximize, the positive effects of that local block so that our patient isn't feeling any pain without affecting our results?
The only complications I've really run into or thought about when I'm doing local blocks is if you're using a product that has epinephrine in it or something that's designed to keep the numbing agent present in that area. If you have an end-on arterial, you don't want to use epinephrine in those areas. But the majority of the time we are not doing that, and we're using straight lidocaine with diluted with zero water and a little tiny bit of sodium bicarb, which isn't essential, but from personal experience, it feels better. And sometimes if you just use a large amount there, then it might bleed excessively, but excessively is from a dermatologist's perspective, completely different than excessively from a surgeon's perspective.
Surgery.
Yeah, very, very different. And so I'm just more impatient when it's oozing or such that I can't suture fast enough, or someone has to blot for me or what have you. And so it's not a life or death kind of situation. Oh, it better not be anyway in my part of the hospital. And so really complications are rare. It's just when you're trying to block something, that a digit or an extremity of some sort, a toe, like sometimes I'm taking off a sebaceous hyperplasia lesion on a digit or something. That's really hard to block that because there's so little sub-Q tissue there. And so I don't know that I have a great answer for that. It's just a couple of different tries and trying to diffuse the area as much as possible without exceeding the volume for a small dog, if it's a dog or a cat.
Yeah, I guess that's one thing that we always want to keep in mind, especially with little cats, is just to be really careful with that lidocaine dosage. So, and then you touched on this a little bit because you said that you don't want to clip your skin, but sometimes we do need to remove the hair. So when we're preparing the biopsy site, how do we strike that right balance between preserving the sample, the crust, the things that they want, but also making sure that we get really optimal visualization of our lesion that we're biopsying?
I just use some scissors usually to trim the hair if there's a lot of hair in that area. We actually use a lot of bikini clippers, which sounds kind of bizarre, but you get really small areas. You can clip easily and you don't get too much hair, but We had a new set of brand new clippers recently, and I was looking for some great lesions. I ended up clipping a half the side of the dog before I realized how much hair I took off. And I told the owner, I said, but the side is great. You can look at all the lesions we can see. I got great pictures. So look at the side, but it was actually really necessary. In that situation, the veterinarian that referred the case had biopsied the dog the week prior, and it only because I was clipping and looking, and I had the advantage of knowing that her biopsies didn't give her an answer. There were a few clues, but it just happens to be what she biopsied was very appropriate. I just probably took more hair, and I knew what I was looking for specifically. But those are very frustrating scenarios for owners and for veterinarians when all the diagnostics are appropriately chosen, but the results are very different. And so clipping is important, and sometimes you just have to just remove that hair as much as can, but you don't want to disrupt, like you said, the surface, the crust. And so just trimming is ideal, but leaving the surface intact as much as possible.
Yeah, it can be amazing how much those lesions hide underneath the really long-haired cats or long-haired dogs. Once you get that hair out of the way.
Yeah, and that is a challenge. I don't usually get excessively, enthusiastic with the clippers, but they were brand new and they were like butter, so nice. I kept seeing more lesions, and I was like, please take the clippers away from me. But you did get the answer, and it was a nice case, and the owner was fine with that, of course. But at the time, I was like, oh Lord, oh no, I have to go talk to her.
So let's talk a little bit about culture. Okay, so skin culture. What are specific considerations for selecting sites when you want to do a culture in addition to your histopathology?
Okay, anything that's deep or draining. Some of the terminology, the casual speak we'll use is if it's a lump, a bump, or a draining tract, then you want a biopsy and you want deep tissue culture for that. And so the reason being, the differential diagnoses are either in the infectious category, the sterile inflammatory category, or the neoplastic category. In the biopsy itself, the histopathology is going to rule in or rule out the neoplasia usually. And then the rest of the processes are going to be pyogranulomatous. And so it could be sterile, it could be infectious. So without that tissue culture, you don't know. And you end up having to either guess or go back and repeat the process to get your tissue cultures. And that's frustrating and costs, more time and money for the owner and the veterinarian. And so getting it from the very beginning, but it's a lump, a bump, a draining tract, it's deep, then you want to get a tissue culture if it's financially feasible from the very start.
And how does your technique for sample collection differ if you're going to be collecting tissue samples for culture?
Tissue samples for culture are something that you want to get right from the very beginning. And so I'm using sterile instruments anyway, but I'm going to be very, very cautious about my technique and making sure that I'm actually going to scrub the surface lightly for a culture sample, because I don't want the surface. I want the deep stuff that's walled off in all of the fibrous tissue or in the pocket. And so the surface doesn't matter with that sample. So I'm going to lightly scrub it. I'm going to rinse it thoroughly because I don't want that chlorhexidine or whatever scrub I'm using to dilute my sample, when I'm removing it. And then I'm going to use sterile gloves, sterile instruments, sterile gauze, all of that. And then once I've got that sample and it's safely in the culture container, the petri dish, the red top tube, whatever you're using to transport it, I know for certain a culturette is not what the microbiologists want. They will not be very happy trying to dig your chunk of tissue out of the media. They want a red top tube or a sterile container. And if you don't know what they prefer, I would definitely check with the lab. But get that, once that's in the tissue in the sterile container, then we're being clean and we're still using good technique, but the sterility is not the essential part. Now we want to preserve all of the architecture, and we're not clipping. We're not scrubbing, we're not cleaning, we're leaving it all alone. We might trim like we mentioned earlier, but there's no surface preparation for the histopathology part.
Okay. And then you have a couple tricks as well when you're preserving your biopsy samples with an index card or tongue depressor. Could you explain that to our audience?
Of course. Once the sample is in the formalin, the color disappears for the most part, and the pathologist doesn't know which is up and which is down, especially if there's an alopecia lesion. And so it's helpful to preserve the architecture as much as possible when they're trimming it into the paraffin block, and then they're making the slices basically. But it helps them orient the tissue when they're placing it and getting ready to trim it. And so it's more of a helpful tip for the pathologist to be able to see what's top, what's bottom. And the important thing is to make sure it's upside down in the formalin, though. If it's floating like a little boat, then it's not going to get fixed and it's a useless sample. And so making sure it does get turned over. I suppose people could use cassettes or something like that to submit it. Just some way to get the communication to the pathologist, which part's up, which part's down, if they can.
Absolutely. And then are there any additional precautions or tips when you're preserving the samples to keep them effectively until they reach the laboratory? I have definitely had a problem where I have included samples with formalin in the same bag as samples that I've sent for cytology, and that has caused some problems.
Yeah. Actually, when I was at Iowa State, I asked the pathologist to call me when they had a sample that was unable to be used, and sometimes the samples were frozen. And so in the middle of the winter, if it was too big for the formalin, right? And so I have some great samples, pictures of frozen tissue samples that were supposed to be, formalin fixed. And, you don't think about those things sometimes. Or the sample, if it's a larger piece of tissue, I'll incise into it. So the formalin fixes the center of it and make sure that it gets all the way through. And then back to that rule of, a ratio of 10 to 1, 10 formalin to 1 tissue kind of is what we've been taught to make sure you have enough formalin to fix all that tissue. And then I separate my samples into individual jars. And so each sample's in a different jar, and then based on which clinical lesion I've chosen, and then they're labeled that way. And most of the laboratories, at least the ones I'm familiar with, do not charge any more for having multiple cups, as long as it's all the same. It's skin, it's not skin and liver and lung, whatever. And so those are my tips, because sometimes you biopsied something, like we said earlier, that should be a hairless tissue, but they're reading out haired skin. That doesn't make any sense. And so trying to catch those things so you can communicate with your pathologist when you're trying to figure out what's going on.
And then the final step when we get done with our biopsy is actually to close that site. And you said you have someone coming along behind you and suturing up for you. I want one of those.
Yeah, I know. The students are amazing, and I defer all the time. Sometimes they think I'm kidding, but I'm like, what would you like to do with this closure? I've created a little bit of a large wound, or we have a brand new CO2 laser, and sometimes I have a little excitable with the laser. I like it, but then I'm asking them, what kind of closure do you want? They think I'm humoring them. Like, no, really, what should I do? What should I do here? But most of my lesions, and honestly, I haven't even biopsied so much. I'm directing and I'm being the cruise director, but to my residents and students, I'm letting them do the job and showing them how it's not technically challenging to do these things. It's really just about thinking and organizing yourself and keeping track of what your samples are and where they're going. But simple interruptives, I use simple interruptives if I'm trying to keep things very cosmetic. Cruciate pattern is absolutely acceptable. The one thing I will remind people, and myself included, is not to use non-absorbable suture in a nasal planum, for example. Trying to remove those sutures without a sedated patient is not easy. And I did that to myself not long ago. And I was like, wow, these poor veterinarians are probably, no one's called me and said, hey, by the way, please don't do that. That's hard. Because I had to do it myself. And it was really, I was like, wow, this is it's not easy. So absorbable sutures, of course, in certain areas where you don't want to have to sedate the patient just to remove the suture. But simple interruptives are nice. And every once in a while, we'll do a intradermal or not usually a subcutaneous pattern, but there are some times when the lesions are deeper than I expected, and we'll have to do a second layer and then close with the standard skin sutures.
And then close on top. Do you ever leave, a small biopsy site open just to granulate in, especially I know around the nose or the nasal planum or the paw pads, where you can get, if you try to put a suture in, sometimes it ends up being really non-cosmetic and puckered.
Mm-hmm. Right. Yeah. Some of those areas are just not suitable for closure, and they close nicely, and that there's nothing important going to fall out in my part of the hospital, at least. That's the way sometimes owners are very concerned, and I remind them that there's no organs that are going to fall out. It'll be fine. But we want it to look nice, but sometimes it's not possible. It's just not enough, like you said, not enough subcutaneous tissue to close that nicely.
Okay. Well, that was the end of all my clinical questions.
Okay, excellent.
Our regular listeners know that this is the time that we get to ask some fun questions. So we play a little
Great.
game at the end of our episodes. It's just a series of would you rather questions. So would you like to play
Okay.
with this?
Yeah, I'd love to.
All right. So would you rather someone steal your favorite pen or someone throw away your skin scrape spatula?
Oh, pen for sure. Yes, for real. I'm a pen person. I like my pen. Well, people that know me from Iowa State, I had a very specific pen pattern in my pocket. And Dr. Noxon is the notorious using one blade spatula for decades. And
Forever and ever.
Mm-hmm. And
nice
we
and
differed
dull.
on that. We differed in that in case there was a couple situations where I found some Demodex mites on a case that was from a previous case. And I was like, oh, ho, ho, look what happened. And so we had a fun, back and forth about that. But I'm pen, please don't throw my pen.
Okay. Would you, do you generally prefer to treat your own pets or do you prefer to have a trusted colleague do it?
Oh gosh, irrational owner. And I am the worst history giver of my own pets. And so I just hand them over and I just all the things that we tell owners not to do is what I do. One dose didn't work. Let me switch this. Let me do that. So I hand it over and I just tell them, go forth.
It's
please.
Better to let someone else take care of it.
Mm-hmm, mm-hmm.
All right. Would you rather find out that the puppy you were just snuggling has scabies or that the 5 kittens you just examined all have ringworm?
I think ringworm's okay. Ringworm's okay with me. I've given myself ringworm by inoculating myself when I was doing a lab set up at Iowa State and not wearing gloves like a smart person. But it clears pretty nicely with some terbinafine from the foot care aisle.
CVS.
Mm-hmm. Yep, we have a rescue facility, a tiger rescue facility in our area, and many times the animals are here for other workups. And there was a group of folks that got some ringworm from the tigers, and we had a big terbinafine. Everybody had their own terbinafine. I was not involved, but everyone had their own terbinafine tube walking around, and everybody was fine. The scabies situation, though, not a fan.
Yeah. I don't think that I have ever gotten ringworm from a dog or a cat, but my grandfather had a dairy farm in Iowa.
Oh, yeah.
Mm-hmm. I swear, if I am within 10 feet of a cow with ringworm, I have it. Mm-hmm. I don't know.
Wow. That you probably don't get poison ivy. That's one of my mentor's theories is that you either get poison ivy or dermatophytosis. You don't get both.
You don't get both. That's interesting. Based on we should run a study.
Yeah, based on your immune system, the way your T cells get activated. So I think she's right. She's right about lots of things, though.
All right. 2 more questions. Would you rather practice without topical steroids or without oral steroids?
Topical by far. They're the bane of my complications.
Don't.
Yeah, the topicals can really mess things up a little bit. Not the end of the world, but I've learned a lot about potency from the topical steroids that are out on the market, and even in the human world. I have a lot of clients that are MDs, and some of the things they use, I'm like, wow, I had no idea this existed, and it's really strong.
Mm-hmm. All right, last question. Would you rather be covered in fur or covered in scales?
Oh my gosh. Oh no, I don't know. This is a little uncomfortable. I'm gonna say scales, I guess, because those could be glittery and all kinds of different colors and sparkly. And fur, I don't know. If it falls out and you're patchy, I just don't know if I like the moth-eaten look. I think scales is what I'm going to go for. They're more decorative.
I like that. I like that answer.
Yeah,
I usually go with fur because I'm always cold, which is why I moved out of Iowa. Gotcha. But I like the decorative aspect of scales. I might have to reconsider.
You can bling that up. It's all kinds of iridescent things. I mean, I think you can really do a lot with that.
Okay. Well, that was it. That was all my questions. Those were fantastic answers. We had so much fun today. Hopefully, maybe you can join us again sometime.
I'd love to. Thank you so much.
Thank you all for listening to today's episode of Clinicians Brief the podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version that we have on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts. Or, if you'd like, drop us a line at podcasts@vetmedics.com. Clinicians Brief the Podcast is a VetMedics production, produced by Alexis Ussery and hosted by me, Dr. Alyssa Watson.